In this last clip of our chapter on regeneration and healing, we'll finally get to what you hoped we would get to, and that are things which are more clinical than some of the basic research that we talked about before. There's always the desire to understand the difference between what they call healing by first intention from healing by second intention. And do you remember at the beginning we talked about the amount of fibrosis which occurs after inflammation, and with this healing process now is determined by the degree of disruption or destruction of the intercellular matrix? You remember that? Well, that's the prime concept that differentiates healing by first intention from healing by second intention. When you heal by first intention, think of a tissue that has been very cleanly cut with a scalpel, like in surgery. Well, because there's very little disruption of the connective tissue, you can basically put the two ends back together, and when it heals, it winds up being pretty much exactly like it was before, with minimal scarring. If, for example, you had a wound like a dog bite, or somebody just gouged out tissue traumatically, there's significant disruption of the ECM, and therefore that is much more likely to heal with scarring. So the end result is, in first intention healing, the edges of the wound are lined up. In second intention wound healing, the edges are not lined up, and therefore there's more granulation tissue, more neovascularization, more organizing inflammation, more epithelialization, and more fibrosis. End result is there's a lot more scarring with second intention wound healing than with first. Here's my favorite diagram. Because we talked about things like inflammation, granulation, and fibrosis like they were separate processes, I wouldn't want to give you the impression that they are. They are generally separate, but they overlap tremendously. So when we talked originally about inflammation, we would never have thought of the appearance of blood vessels or scar tissue at the very beginning. But if you take the period of granulation or neovascularization, that can very much overlap both functionally as well as histologically with the inflammatory process. And similarly, when we look at the ingrowth of new blood vessels and the appearance of fibroblasts and collagen and scar formation, that overlaps with the granulation phase as well, doesn't it? There is very little overlap, in fact probably none, between classical acute inflammation and fibrosis. The intermediate curve, however, is your neovascularization phase. It would be inconceivable for fibroblasts to appear in inflammation earlier than several days, and up here they'll give you the appearance of perhaps 3 at the very earliest, but more likely a few weeks, which is why if you see any process that has fibroblasts and scar and collagen in it, you know it is not recent. This is what granulation tissue is going to look like in your patients when you look at them after surgery. It's nice and puffy and pink and red because and it may even contain a little bit of yellowish type material, which is fibrin, but don't get that confused with pus. This is not an infected wound. This is a clean wound. And this is a clean wound also. It's puffy because of the granulation, or what the resident might call ticking, meaning, what does the word ticking mean? Actually, I don't know. But often I've heard that term used before. All it means is healthy granulation tissue. And microscopically, you may still have some remnant of inflammatory cells. You will have a predominant vascular pattern. There's a blood vessel, there is. Some of these other cells may be primitive endothelial cells, connective tissue cells, which will give rise to blood vessels. But you don't see much fibrosis in here, do you? Fibrosis occurs later than granulation. And not only does it occur later, by that I mean weeks, months, even years, but as time goes on, the collagen becomes more dense, has more tensile strength, and therefore the tissue is stronger. So can we perhaps say that which doesn't kill you makes you stronger? Is this the histologic example of it? Perhaps. Let's get very clinical again and talk about what kind of things are going to retard healing. Well, there are both local factors and there are also systemic factors. The local factors and systemic factors both have as their number one factor blood supply. And even though we're going to talk about a few other things, the main process in healing is blood supply. Locally, if something is not innervated correctly, even if it's not a muscle, it's not going to heal as well as something that is. If there's still persistence of a local infection or the presence of a foreign body or a big blood clot, perhaps causing causing too much pressure and inadequate blood flow, that would be another reason for a local retarding factor. If there's mechanical stress, perhaps from a cast that's not on right, or the presence of necrotic tissue in itself, even if it is not infected, will also be a local retarding factor. But remember, folks, if you get to be 80 and you get Alzheimer's disease and you can only think of one thing, for both local and systemic, adequate blood supply is the number one factor. So here we go to the systemic factors. And do older people not heal as well as younger people? Yeah. Do people who don't have enough oxygen going to tissues and wounds and areas of inflammation not heal as well as non-anemic people? Yeah. Do people with malignancies, perhaps due to some immune deficiency or not heal as well? Yes. Do malnourished people not heal as well? These are all logical, aren't they? Do obese people not heal as well as non-obese people? You betcha. And do people that still have the presence of systemic infection not heal as well? Yes. Do people with major organ failure of any major organ, kidney, liver, anything, not heal as well? Yes. But once again, decreased blood supply is also the number one reason for a retarding factor systemically. And thank you very much. We are completely done with Chapter 3.